Are my slides visible? Okay. So today, I think we'll continue with our discussion on electrolytes. We had discussed about hyponatremia earlier in 2 classes. Hypernatremia is something which we never discuss, or we don't think hypernatremia is as important as hyponatremia, but it's not true. Hypernatremia is equal or if not more important than hyponatremia. So the slides are not moving. No, slides are not moving. That's what I'm saying. Okay, so I'll start again. I know I should make sure the slides are moving. No, slides are moving. I should make sure. No. Okay, let me say. Let me start again then. So today, I think we will be discussing about hypernatremia. Earlier, we spent 2 sessions on hyponatremia. Always, whenever I'm asked to talk about sodium, I discuss about hyponatremia. Hyponatremia is equal or more important than hyponatremia. So I think we should spend an hour or so in discussing hyponatremia today. So the next 45 to 50 minutes, we will just discuss the definition of hyponatremia. What is the probable pathogenesis? How do you classify hyponatremia? What are the causes of hyponatremia? And how will you arrive on the basis of an algorithmic approach? And what is the basic treatment of hyponatremia? So let us see the definition first. It is caused by a decrease in total body water. It is not a true increase in sodium. It is a decrease in total body water. So the even sodium gets concentrated in a lesser amount of water and makes the sodium concentration high. So it is caused by a decrease in total body water relative to the electrolyte content. Whenever we talk of hyperosmolality, we think it is a problem of sodium. It is not a problem of sodium. It is a problem of water. More water produces hyponatremia. Less water produces hyperosmolar state and hypernatremia. Okay. So whenever there is hypernatremia, we will see it results in cellular dehydration. So the whole problem is because of cellular dehydration that is happening. Why should we recognize hypernatremia? Acute severe hypernatremia is something which develops within 24 hours. Classic teaching is somebody gets admitted with a normal sodium and develops hypernatremia after admission within 24 hours. It is taken as acute. Anybody who gets admitted with an increase in sodium, it is taken as chronic. Why should we recognize that? Because it is increased morbidity. The patient develops many neurological complications associated with hypernatremia. It is a predictor of bad prognosis in critically ill patients. And just like hyponatremia, the rapid correction of hypernatremia can also result in severe neurological deficit and death. Mild hypernatremia is usually asymptomatic. What is serum sodium concentration? It is the function of total exchangeable sodium and potassium in relation to water. So sodium is equal to total body sodium plus total body potassium divided by total body water. That is what gives rise to the sodium in the plasma or serum. Now, how is this, very briefly, how is this plasma osmolality regulated? The normal plasma osmolality is around 280, that is ranging from 275 to 290. It is determined by the concentration of sodium salt. It is not by the actual quantity of sodium salt. It is by the concentration of sodium salt. That is how much of sodium is present in 1 liter of water. That is what you mean by concentration. We also know that plasma osmolality can be calculated or it can be measured. The formula for calculation is 2 into sodium in milliequivalents per liter plus glucose in milligram per deciliter by 18 plus urea nitrogen in milligram per deciliter by 2.8 or urea in milligram per deciliter by 6. This formula we have discussed earlier also. The 2 sodium is sodium, exists as sodium chloride. So it dissociates into 2 ions, contributing to osmolality. When you measure the osmolality using the osmometer, the principle employed is freezing point depression method. So if there is a difference between the measured osmolality and the calculated osmolality, that is called as osmolar gap, which we will not be discussing today. So what happens? What happens when the osmolality increases? The threshold value is 280 to 290. So when it is allowed to go beyond 290 by failure of the defense mechanisms, it draws water from cells into the blood. It dehydrates the specific neurons in the brain that serve as osmoreceptors or tonicity receptors. And on stimulation, they signal to other parts of the brain to initiate thirst and AVP release. So if these 2 mechanisms are intact, there will be increased water intake, increased reabsorption of water, and hypernatremia will not develop. So regulation of plasma osmolality and sodium is determined by changes in water intake and water excretion. Again, it is not by sodium. The take-home point is it is the water that determines the sodium and not that sodium determines water. Water determines the sodium. So prevention of hypernatremia, usually everybody will develop hypernatremia at some point of time, but there are 2 effective mechanisms which will prevent the prevention of hypernatremia. Let us see what is the first mechanism. Whenever somebody develops hypernatremia, there's a thirst center in the hypothalamus which gets stimulated, and this stimulated of thirst increases the water intake, and this increased water intake decreases osmolality and thereby sodium. So if somebody has got an intact thirst center and the patient is able to access to free water, hypernatremia will not develop because thirst mechanism is so effective. And that is why in Malayalam we say uppu tinnavan vellam kudikum. That is, whenever you take salt, there is an increased osmolality that will stimulate the thirst center and you will drink more water. So that is what shown in this picture. Now, what is the second mechanism? The first and the most effective mechanism is thirst. So if somebody's thirst mechanism is intact and water is accessible, whatever happens, hypernatremia will not develop. The second mechanism is by the kidney and the artery vasopressin. Plasma osmolality and the volume status tightly regulates the secretion and action of AVP. Osmolality takes the upper hand than volume. If somebody is hyperosmolar and hypovolemia, hyperosmolality will be the dictator for the release of artery vasopressin. So when the plasma osmolality is equal to or above 280, that is activation of the hypothalamic osmoreceptors. And when the osmoreceptors are stimulated or activated, they increase ADH. So whenever there is an antidiuretic hormone release, there will be retention of water and the plasma osmolality will get corrected. On the other hand, if somebody has got a plasma osmolality of less than 280, there is a suppression of AVP release and the AVP will be low or undetectable. So the main stimulus for the AVP release is hyperosmolality and low volume. The other factors being decreased effective arterial blood volume, pain, nausea, anxiety, drugs. So the post-surgical state or extremely painful situations, there is excessive ADH release. That is one of the reasons for hypernatremia in these situations. So what is this arginine vasopressin? It is synthesized in the specialized magnocellular neurons. The cell bodies are located in the supraoptic or paraventricular nuclei of the hypothalamus. The axon in cell body terminates in the posterior pituitary gland. The prohormone secreted by hypothalamus gets activated and is secreted as an active AVP hormone into a circulation. Again, the stimuli being hyperosmolality, hypovolemia, the other stimuli being pain, drugs, etc. So what is the mechanism of action of AVP on the kidney? AVP binds to the G protein, which is coupled to the V2 receptor. There are V1 and V2 receptors. Here we are talking about the V2 receptors. It is located on the basolateral membrane of the principal cells of the renal collecting duct. So this AVP gets bound to the V2 receptor. It initiates a signal transduction cascade, phosphorylates aquaporin 2. They are water channels, and these water channels will get inserted into the apical membrane. That is, the apical membrane is a lumen through which the urine flows. So when the water channels get translocated in the apical membrane, more water enters the cell and gets shifted in the blood, leading to retention of water. So that will dilute the sodium and normalize the osmolality. So this is the mechanism of action of AVP. AVP binds to the G protein V2 receptor. The site is the luminal membrane, principal cells of the renal collecting duct. It phosphorylates aquaporin 2. Aquaporin 2 are the water channels that gets translocated into the apical membrane and leads to reabsorption of water. And this collecting cell is otherwise impermeable to water. So only when there is ADH, this segment will get activated, allow water to enter the cell and there get shifted to the blood. That is why I said whenever the osmolality is low, there is no ADH. So the water, this segment will continue to be impermeable and no water will enter the bloodstream. So to summarize the defense mechanisms, increased osmolality, there is a second defensive mechanism, decreased secretion of ADH from the pituitary, causes decreased water secretion, decreased free water clearance as a result of ADH and V2 receptors, leading to the insertion of water channels or aquaporin 2, mainly in the collecting duct, which allows the water to get shifted to the stream and correct the osmolality. So having discussed the defense mechanism, how does one develop hypernatremia? The first and foremost cause is a hypotonic fluid loss. What do you mean by hypotonic loss? If the fluid that is lost has got less sodium than the fluid that the plasma, that is called as a hypotonic fluid loss. That is the most common cause. Again, it will be aggravated if you try to correct the hypotonic fluid loss with the isotonic fluids. So the hypotonic fluid loss is the most common cause, which will be aggravated when we try to correct that with an electrolyte-rich solution, which is inadequate in pure water. That is the first cause. Second is a pure water loss. No electrolytes are lost, only water is lost. That also gives rise to hypernatremia. Third is the gain of sodium. We will see with examples. So based on the ECF volume, again, hypernatremia, just like hypernatremia, can also be classified into hypovolemic, where the loss of water is less than sodium, euvolemic when there is only a pure water loss, and hypervolemic when there is a sodium gain. So let us see with an example, what do we mean by a hypotonic loss of fluid, the ECF? that is net loss of water and sodium from the body. But the loss of sodium, the fluid that is lost, contains less sodium relative to water. And when you are replacing that with normal saline, that is inadequate in water content, that can produce hypernatremia. So let us see the example. If 300 ml of water with 30 milliliters of sodium is lost from 1 liter of extracellular fluid, the current sodium will be 140 minus 30. What is this 140? That's a normal plasma serum sodium divided by 700 into 1000. So by just losing a 300 ml of water, which is less in sodium, the serum sodium will rise to 157 milliequivalents. That is hypernatremia. Any sodium more than 145, we said is hypernatremia. If you try to replace this 300 ml of normal saline, if you are replacing this fluid with 300 ml of normal saline, the sodium, instead of getting 30 millimoles, you are giving around 46. So this 46 sodium gets redistributed in a lesser amount of water, and the sodium becomes 156. And the sodium becomes 156. Replacement solution here should be 300 ml of water, which contains only 30 milliequivalents of sodium. If you use normal saline, we know that this contains, excuse me 1 minute. Hello? Hello? Ah. Hmm. Hmm. Ah. Hmm. അത് ഇത്രയും വാസോകൺസ്ട്രിക്ടേഴ്സ് കൊടുക്കുന്നവർക്കായിരിക്കും. നോക്കാം. Okay. So, sorry, I had a call from the hospital. The replacement solution is 300 ml with 30 milliequivalents, which is 16 milliequivalents less than normal saline. That should be the ideal fluid. So the bottom line is loss should be replaced with a solution which has the same composition as the fluid that is lost. Otherwise, it can result in hypernatremia. Example 2 is pure water loss. When 300 ml of water is lost from 1 liter of ECF, which contains 140 millimoles of sodium, there is no sodium in the fluid that is lost. The sodium will be 140 by 700,000, that will become 200. So here, the fluid that is lost does not contain sodium, but the water that is lost increases the concentration of sodium, giving rise to hypernatremia. The third cause is an increased sodium load. If 50 ml of 7.9% sodium bicarbonate is infused, 1 ml of 7.9% sodium bicarbonate contains 0.9 milliequivalents. So if you give 10 ml, it will contain 45 millimoles of sodium. So the new sodium will be 140 plus 45. So gain of sodium, either most common cause is infusion of sodium bicarbonate. Very, very rarely, excess of salt intake can also result in hypernatremia. That is not very usual, because once we consume excess of salt, it will stimulate immediately the thirst mechanism. We will drink more water and correct the hypernatremia. So what happens? Why are we worried about this hyperosmolality and increase in sodium? As we see here, whenever there's an increase in sodium, there is an increase in serum osmolality. So, the cell and the ECF should have the same osmolality. They cannot be different. There should be an osmotic equilibrium. So sodium enters the cell through the electrical and concentration gradient, but sodium cannot stay there. It is immediately pumped out of the cell by the sodium potassium ATPase. So what will happen? The ECF osmolarity continues to be high. The cell has got a lower osmolarity because the solutes cannot come out. The water comes out to the ECF and dilute the ECF to normalize the sodium. So that produces a cellular dehydration. Whenever the cell shrinks, there is stretching of vessels. They can result in cerebral and subarachnoid hemorrhage. So to repeat, whenever there is hypernatremia, there is hyperosmolarity. Whenever there is hyperosmolarity, to attain osmotic equilibrium, because the solutes are impermeant, the water has to come out of the cell. So whenever the cell loses water, the cell shrinks. Whenever the cell shrinks, the vessels get stretched, it bleeds, producing a cerebral and subarachnoid hemorrhage. What are the normal renal compensatory mechanisms? So whenever there is hypernatremia, water should be retained. So there is a reduction in GFR. There is an increase in reabsorption of sodium and water from the proximal convoluted tubule and distal tubule because of ADH. And there is a decrease in free water clearance by the action of ADH in the collecting duct. These are the normal compensatory mechanisms. Failure of the above mechanisms can result in hypernatremia. So the renal compensations are reduction in GFR, increased proximal tubular reabsorption of sodium and water, and decreased release of ADH. So decrease in free water clearance, thereby correcting the osmolarity. Failure of any of this can result in hypernatremia. But to reiterate, reduction in free water intake, there's an intact thirst mechanism and accessibility to water. Even if there's a failure of the renal mechanism, hypernatremia will not develop. In chronic hypernatremia, what happens? To prevent cellular dehydration, electrolytes will be transported from the ECF to ICF. There is also synthesis of new intracellular osmolytes, which occurs within 24 to 48 hours. So the cell attains a new osmotic equilibrium at a higher osmolarity. So if you have a chronic hypernatremia, naturally by your defense mechanisms, there will be an equalization of osmolarity, but instead of staying at 280, the cellular osmolarity and the ECF osmolarity will be around 300. So there is no disequilibrium, it is an equilibrium. So when you correct this with hypotonic fluids, the ECF osmolarity decreases. That is, cells have a high osmolarity, solutes cannot come out. So to attain osmotic equilibrium, water moves into the cell, resulting in cerebral edema. So the neurological sequelae of hypernatremia is due to 2 points. One, acute hypernatremia resulting in cellular dehydration, stretching of vessels, subarachnoid cerebral bleed. Rapid correction, fluid will enter from the ECF into the cell, producing cell swelling and cerebral edema. So what are the causes based on classification? We said can be hypovolemic, euvolemic, or hypervolemic. So whenever there is excessive fluid loss from the skin, as in high temperatures, heat stroke, burns, loss of fluid, kidney disease, diarrhea. There are certain diarrheas where you lose water more than electrolytes, vomiting, diuretic use. The patient can develop hypernatremia. Euvolemic is usually the thirst mechanism is gone. Hypodipsia or adipsia. Diabetes insipidus, which we will not be discussing today. Lack of access to water. Lithium overdose. Somebody is on lithium for MDP. That can result in euvolemic hypernatremia. Hypervolemic hypernatremia is when we use 3% saline or a wrong fluid for correction of fluid that is lost, or sodium bicarbonate overcorrection for acidosis can now result in hypernatremia. So what are the causes? CNS causes. Usually the disease of the hypothalamus affecting the thirst center. Or when you are trying to feed somebody through the rice tube, we have tendency to give only electrolyte-rich solutions. We don't give free water. Actually, you have to calculate the water requirement and feed them through the rice tube. Otherwise, we are responsible. The iatrogenic cause of hypernatremia is very high in patients who have brainstem stroke or hypothalamic injury or a protrophic accident when we try to feed them with colloids or alkylate solutions. So inadequate water intake is rarely a cause in alert patients where the thirst mechanism is intact and have access to water. What are the risk factors in the community? In India also it is becoming more and more common when people are staying in old age homes, etc. Extremes of age, underlying neurological disorders, primary hypodipsia, diabetes mellitus, diabetes insipidus, and other polyuric states, they're all risk factors in the community. So other polyuric states we know are when somebody recovers from acute kidney injury, there is a diuresis. When somebody has got hypercalcemia, there is a diuresis. So these are some of the risk factors for somebody to develop hypernatremia in the community. What are the risk factors in hospitalized patients? Tube feeding with concentrated solutions and less free water. Use of osmotic diuretics like mannitol for cerebral edema, which produces osmotic diuresis, which produce more water loss than alkalies. When we use lactulose, especially in hepatocellular injury, that produces osmotic diarrhea, which contains more water, and mechanical ventilation. These are some of the risk factors in hospitalized patients. What are the clinical features? The clinical features are when there is chronic hypernatremia, that is when it is documented after 48 hours, it is usually asymptomatic. Somebody has got a normal sodium on admission and develops hypernatremia within 24 hours, they become symptomatic. Usually symptoms develop when the sodium exceeds 160 millimoles per liter. The symptoms are usually non-specific. It can be fever, nausea. It can be due to neurological complications. The patient may also complain of increased thirst. It is not as common as hyponatremia, but it occurs in 0.5 to 5% of hospitalized patients. Increased morbidity and mortality in the geriatric age group for the reasons stated above, because they are not complaining of thirst and they are not able to satisfy their thirst by taking free water. Mortality rate for acute hyponatremia in the ICU is around 75%. Whereas chronic hyponatremia has only a low mortality of 10% when compared to acute hypernatremia. So what happens in hypernatremia? In hypernatremia, we said there is a water deficit, there is a sodium retention. So whenever there is a water deficit, there is a volume depletion. When there is a volume depletion, the GFR comes down. It produces acute kidney injury, which can give rise to hypotension, GFR, low GFR, and oliguria. Sodium retention results in natriuresis. So hypernatremia, there is water deficit. If there is also sodium retention, water deficit can produce CCF depletion, acute tubular injury, resulting in renal failure. The important neurological complication is hypernatremic encephalopathy, characterized by thirst, excessive thirst, confusion, irritability, alteration of sensorium, muscle spasm and hyperreflexia, seizures, especially in children, and it may be an important cause for the mortality. They become comatose and we lose the patient. So whenever you think a patient who was stable with a cerebrovascular accident or something or the hospital, and the patient worsens the neurological status, which cannot be accounted by the vascular mechanisms, you should always exclude a metabolic cause. So hypernatremia is one important metabolic cause for worsening of neurological status. So depending on the system that is involved, the symptoms also develop. Cognitive dysfunction and symptoms associated with neuronal cell shrinkage. We earlier said whenever there is a hyperosmolality, the ultimate effect is cell dehydration. That can give rise to neurological symptoms, lethargy, obtundation, confusion, abnormal behavior, seizures, nystagmus, myoclonus, etc. It can give rise to volume dehydration. Ideally, when you say hypovolemia, it is sodium loss more than water. When you say dehydration, it is water more than sodium. So though we use it interchangeably, correctly dehydration, you say the patient is dehydrated, the implication is there is a water loss more than sodium. When you say the patient is hypovolemic, that means the patient has lost more sodium than water. So there will be clinical sign of volume depletion. We also discussed this when we discussed the fluid therapy. The earliest sign being postural hypotension, postural tachycardia, persistent hypotension, persistent tachycardia. Patient may develop dry oral mucosa, abnormal skin turgor, increased longitudinal furrowing of the tongue, and oliguria. If you are able to monitor the bed with the weighing machine, bed weighing machine, there will be weight loss and generalized weakness. What are the adverse prognostic factors? When somebody has got hypernatremia, what are the contributing factors? Low systolic blood pressure, low pH, that is acidosis. If the absolute value of sodium is more than 166, there is an increased plasma osmolality. And when you try to correct, the sodium reduction rate is less than 0.13. If they are severely dehydrated and has got a respiratory complication, pneumonia, there are adverse prognostic factors. Now, how will you evaluate for hypernatremia? What are the steps? How will you find out what is the cause of hypernatremia? As in hypernatremia, the first step is assessment of ECF volume. That is, you should identify whether the patient is hypovolemic, euvolemic, or hypervolemic. Next step should be measurement of urine osmolality and urine sodium. Then you have to compare the urine osmolality to plasma osmolality. Measure urine sodium, potassium chloride and compare to urine osmolality. If urine sodium and potassium is or the chloride is less than sodium plus potassium, you have to measure urine pH. Last two will not be discussing today. So the first three steps are assessment of ECF volume, measurement of urine osmolality and urine sodium, compare urine osmolality to plasma osmolality. So how will you approach hypovolemic hypernatremia? As in any other medical problem, a detailed history will enable you to find out what is the type of fluid that is lost and why this patient has developed hypernatremia. That is the most important thing. To time and again, we have all investigations, but nothing to beat our clinical diagnosis and clinical knowledge after detailed history and physical examination. The most investigative modality we use is urine osmolality and urine sodium. If the patient has got a high urine osmolality, some say 600, some books say 700, and low urine sodium less than 10, that means the kidneys are trying to conserve water. That is why the urine osmolality is high. And sodium is also being conserved. So urine sodium is low. Here kidney is not the culprit. The usual causes are extrarenal causes. As we discussed earlier, loss of fluid through skin, respiratory tract, loss in hot environment, exercise, febrile patients, and patients on mechanical ventilator. Inadequate water intake as in extremes of age, patients with neurological disorders, primary hypodipsia, or there is a condition called reset osmostat in the elderly. Your osmoreceptors are set to a higher osmolality than a low osmolality for simulation. So the first step should be measure urine osmolality, urine osmometer, or using the formula, and urine sodium. If urine osmolality is more than 700, that means it is a concentrated urine. That means kidney is conserving water and electrolytes. That is why the sodium is also less than 10. So you have to focus on these causes. If the urine osmolality is low and the sodium is high, that means there is a dilute urine. The plasma osmolality was high, So you would have expected the urine osmolality to be high if the kidney is behaving properly. But the urine osmolality is low and the urine sodium is more than 20, that means there is increased excretion of osmoles in the urine with increase in volume. In the earlier case, there was increased excretion of osmoles in a lesser volume of water. Here, the volume of water is increased disproportionate to the increase of excretion of osmoles. This happens in osmotic diuresis. Somebody is a diabetic, there is a hyperglycemia, there is glycosuria, there is increased urea excretion as in renal failure. Use of osmotic diuretics mannitol, there will be increased water that is lost. So the osmolality will be low and the sodium will also be increased. Increased volume of urine can also occur in loop diuretics, thiazides, etc. If the urine osmolality is very low and sodium excretion variable, that shows the ADH secretion is defective. It can occur either from the pituitary, when you call it as a central diabetes insipidus, or the collecting duct is not responding to ADH, when you call it as a nephrogenic diabetes insipidus. This we'll be discussing in the next class. So what are the medications that can induce AVP resistance? So whenever you have a hypernatremia, you should go through the drug list. I am not going to read. These are some of the common drugs which can either induce AVP resistance definitely. On the right hand side, you have the agents which can probably produce resistance. So what is the treatment for symptomatic hypernatremia? Find the first and foremost, you have to decide whether to treat aggressively or not. That can be decided by the onset of hypernatremia. If the onset is less than 24 hours, it is acute and aggressive treatment is warranted. If the duration onset is more than 24 to 48 hours, or the patient gets admitted with a documented high sodium, it is chronic. So you should not be very aggressive in your management because the treatment can itself produce cerebral edema, as we discussed earlier. In acute hypernatremia, correct the serum sodium. And the correction rate should be 0.5 milliequivalent per liter per hour. That H is not there. 0.5 milliequivalent per liter per hour. And the daily correction should not exceed 12 milliequivalents. Preferably, it is better to keep it low, 8 to 12 milliequivalents. And the hourly correction should be 0.5 milliequivalent per liter per hour. According to the guideline, you have to measure the serum and urine lactites every 1 to 2 hours. Though we cannot afford to do that, we should measure at least 6 hours early and see what's happening. Most importantly, you should assess the neurological status of the patient. If the patient is neurologically improving, that means the electrolyte imbalance is getting corrected and you can slowly reduce the correction. So in acute hypernatremia, aggressive treatment is warranted. In chronic hypernatremia, you should be very judicious and slow in correction. The rate of correction should not exceed 0.5 milliequivalent per liter per hour. The total should not exceed 12. It should be between 8 and 12. Serum and urine chemistry should be monitored frequently. Along with that, you have to assess the patient clinically and see whether the neurological status is improving. If the neurological status is improving, irrespective of electrolytes, we can reduce the correction rate. So in hypovolemic hypernatremia, restore intravascular volume with isotonic sodium chloride prior to free water administration. That is, if somebody in shock, and when I was working in Kottayam, we had a patient who lived on apple juice and Coke and apple juice. He developed severe hypernatremia and he got admitted with hypotension. Actually, at that time, we were not very sure of what to do. So then we learned that whenever somebody is in shock, irrespective of the sodium, your aim should be to correct the volume. So you have to aggressively restore the intravascular volume with isotonic sodium chloride, or if required, plasma, or whatever electrolyte solution we have, either simultaneously or after correcting the hypolimic status, you can give free water. So as we said earlier, chronic hypernatremia with no or mild symptoms, slow correction. So let us see what happens to this patient. This 50-year-old patient is admitted with alteration of sensorium. He gives history of seizures, no other comorbidities. He is hypovolemic. Blood pressure was 80/60. Evaluation urinalysis is normal. Hemoglobin is 12 gram. His weight is 60 kg. He has a creatinine of 1.4 milligram with a eGFR of 61. Plasma sodium is 160 millimole per liter and potassium is 4 millimole per liter. So as is evident from the findings, he has a low blood pressure, he has other signs of volume depletion, and he has also a high osmolality of serum osmolality of 349. So he has severe hypernatremia and hyperosmolar state. So as we said, the first step should be to measure the urine osmolality. The urine osmolality was 800 milliosmoles per kg. Second step, we have to measure the urine sodium. It was less than 20, thereby showing he had concentrated urine with concentration of sodium. This patient had no obvious fluid loss anywhere, but detailed questioning, he said he had some unaccustomed exertion. So that produced rhabdomyolysis, and the water got shifted to the muscle cells. That was the responsibility for this hypernatremia. So how do you correct? The fluid replacement, we said acute should be rapid, chronic should be slow. When we correct acutely, you have to monitor for cerebral edema. Oral fluids whenever possible. If contraindicated, you can use oral fluids are contraindicated or right tube fluid is not possible. Parenteral fluids can be given. Most important point to remember, even in hypernatremia, patient should get corrected for this hypotension shock initially. What are the isotonic fluids that we can use for correction of hypovolemia? Normal saline, Ringerlac, Plasmalite. Free water deficit correction after correcting shock or simultaneously. How do we correct? Correct hypovolemia, hypotension with normal saline. He received 1 liter of normal saline and 1 liter of rice kanji with 10 grams salt. His blood pressure got corrected. Now let us see. We said whenever there is a hypernatremia, there is a deficit of fluid in the cell. So how will you calculate the fluid deficit? You know, he is only 50 years, no comorbid, premorbid illness. So 60% of the body weight should be taken as water. So 60% of 60 kg is 36 liters. We also know that 40% of the body weight is intracellular water. So 40% of 60 kg is 24 liters. And extracellular fluid water is 12 liters. This patient had a sodium of 160. So the ECF osmolality calculated based on the sodium alone is 320 osmoles. We also said that the cells and ECF cannot have a different osmolality. So the ECF osmolality should be equal to ICF osmolality, which is equal to 160 into 2, that is 320. You know, cells are impermeable to solutes. So the solute cannot enter from the ECF to ICF and correct the osmolality. So essentially, the water has to come out. So we said the ICF osmolality is norm. For that, we should calculate the total ICF osmolality in the normal state. The normal osmolality is 290 and ICF water is 24. So the total osmolality will be 290 into 24, that is 6960, 6960. That is the total ICF osmolality in this 50-year-old 60 kg man with no comorbidity. But the current ICF osmolality, as we deduce from the ECF osmolality, is 320. So this 6960 osmoles gets distributed in a lesser amount of water to give an osmolality of 320. So 6720 divided by 320 gives you 21 liters. So this is a little difficult to understand. I will say that again. The ICF osmolality should be equal to ECF osmolality. So we said ECF osmolality by virtue of sodium of 160 into 2 is 320. But ICF osmolality cannot allow more solutes to enter, but it has to attain an osmolality of 320. So it has to lose water. For that, we should know what should be the total ICF osmolality. So we are multiplying 24 liters. That is the body water, intracellular water of this 50 kgs, 50 years, 60 kg man. That is 24. The total osmolality ICF is 6960. Osmolality per liter is 320. If the total osmolality is 6960 and 1 liter or 1 kg contains 320, the patient should have 21.75 liters of fluid inside the cell. Originally, we said it was 24. So the fluid deficit here is 24 minus 21.75. That is 2.5 liters. So this patient has got an intracellular fluid deficit of 2.25 liters. At least 50% should be corrected in the first 24 hours. Now, how will you calculate? This formula, again, we discussed when we discussed hyponatremia. Rate of fall in sodium is given by sodium in the infusate minus patient sodium divided by total body water plus 1. Here we are using 1 liter of 5% dextrose for correction, which contains no sodium. So the rate of fall will be sodium in infusate is 0 minus 160. The total body water is 36, to which you are infusing 1 liter. So 36 plus 1. So minus 160 divided by 37 is minus 4.32 milliequals. So if you give 1 liter of 5% dextrose to this individual, that will reduce the sodium by 4.32 milliequals. But we also said the rate of correction should not exceed 0.5 milliequivalent per liter per hour. So to give 4.32 milliequivalents, to produce a drop of 4.32 milliequivalents at the rate of 0.5 milliequivalent per liter per hour, this 1 liter can be given only in 8 hours. So if this 1 liter can be given in 8 hours, the patient's sodium will come down from 160 to 154 or somewhere, 156. We also said the maximum correction that is permitted. So this is how we arrive at this value. 1 liter decreases sodium by 4.32. The permissible reduction is 0.5 milligram per hour. So 4.32 divided by 0.5 is 8.64. So the patient should get correct. This 1 liter of fluid can be given over a period of 8 to 9 hours. The maximum permissible fall in sodium should be around 10 to 12 milliequivalents. And assessed deficit is 2.25 liters. So this can be given in 24 hours since it will reduce the sodium only by 8.64 milliequivalents. So this patient can get 2.25 liters of 5% dextrose over a period of 24 hours to bring down the sodium from 160 to 152, which is a permissible reduction. So that is how you correct the hypernatremia. So we should be very careful in the infusion rate. We should periodically monitor the sodium status because only the extracellular status we can measure, and we should assess the patient clinically. So in the last 45 minutes or so, I had been trying to tell you how will you define hypernatremia, what is the importance of recognizing hypernatremia, how do you classify, what are the causes based on classification, how it produces hypernatremic encephalopathy, how can it result in acute renal failure, acute kidney shutdown, how will you approach the problem based on urine osmolality and urine sodium, get classified into whether it's a hypovolemic hypernatremia based on extrarenal fluid loss, where is a euvolemic hypernatremia based on osmotic correction, or a low osmolality, low sodium because of diabetes insipidus. And briefly, I was trying to tell you how you correct the treatment. You should consider the rate of correction per hour. You should also you should not go beyond the total permissible reduction 24 hours. Whenever possible, the oral route is the best route. And IV fluid that we use commonly is 5% dextrose, taking into consideration that the dextrose gets metabolized and it is equivalent to free water. Thank you for your patient listening. Okay. Thank you.